Welcome again to my lecture series. My name is Dr. Arinze Keme. I am a nephrologist and a hospitalist, and so I do practice internal medicine, which I love. It cuts across all kinds of medical conditions while I still take up care of my kidney patients. Today I'm going to be talking about Code Blue, and this lecture is for both medical students who are aspiring to be physicians and physicians who also already work at the hospital, whether you're a general intern, a cardiologist, a gastroenterologist, a dermatologist. The burden of Code Blues still falls on you, and you never know where you'd be, where you might not have an intern or a critical care physician or a cardiologist around. And so you want to know how to tackle the occasional chaos in a code blue situation and remain calm. The ability to control the chaos and remain calm is key. And so this very short lecture is just a practical approach. Now, I know that most of you are ACLS certified or will be ACLS certified, but this lecture is coming from a more practical setting for someone who has run a code 1,000 times with generally good outcomes. I do believe that this lecture will be helpful. So some of the common scenarios you're going to have for code blue calls would be the emergency room if you're an ER physician. They could be brought in by the EMS team already, getting CPR, or they can deteriorate while they're in the ER and go into a cardiac arrest requiring a code blue call. Of course, in the inpatient medical floor, patients can deteriorate and a code blue is called. On common scenarios, which I have personally experienced, visitors by the parking lot, hallway, visiting family members. So a code blue call in most hospitals usually assembles a team comprising the ER providers, the hospitalists or interns, floor charge nurse, nearby nurses, the house supervisor, respiratory therapies, even the lab technicians are part of these. But however, the physician available is still responsible for running these codes, and the responsibility varies with the different hospitals. We've had situations where advanced care providers like the APPs have run codes with supervision, of course, from a physician. So it varies, really. The scenario is different. Either way, controlling the chaos, remaining calm in any of these scenarios will still be, a priority. So some of the steps you can take to ensure a successful resuscitation episode will be one, confirm on arrival. When you arrive the scene as a physician, you have to confirm that there is no other physician that has already assumed the supervisory role to running the code. The last thing you want is running in and you want to start running the code not knowing that a physician is already running the code. And some people might wonder, is it possible not to know? And the truth is, yeah, sometimes the crowd is pretty high and you fail to recognize there is a physician. So once you come in, just announce and ask if there is a physician or mid-level already running the code. That always saves you the embarrassment. And the step 2 is establish and identify what I call your core triangle, which are the major players in your resuscitation plan, and provide specific expectations and instructions. And we'll go through that. The step 3, establish a rhythm for the entire resuscitation plan. I think this is key. Once you have a rhythm in your management steps during a code blue situation, the rest is easy. You're calm. Everybody tends to understand your rhythm, and everybody, joins in what I call the dance of the code blue call. So again, establish your rhythm for the entire plan after you've established your core triangle, and then provide feedbacks to the team both during the process and of course after the process, because even after the process you want to provide feedback for improvements to know areas where things weren't done right or where things could have been better done. And this helps the hospital overall improve in their management plan. And then, step 5, be open to supportive suggestions throughout the episode. At some point, you can call for suggestions, especially for patients who are not responding to the typical resuscitation protocol. And of course, step 6, what is your post CPR management and instructions? You want to know that. So let's start with confirming on arrival that there is no physician. So ask audibly enough. You can just ask if there's any physician or APP running the code, and usually they'll let you know, or the other staff members will let you know. Step 2, establish and identify your core triangle. Now, this is very, very important. I've seen sometimes, physicians run into a code situation and they start running the code without trying to establish their core triangle. This is, I can't emphasize this enough. This is key, to a successful code blue management plan. So you need 2 staff members for chest compression. So what I usually do is when I come into a code situation, someone is already doing CPR. I usually ask for volunteers, anyone to volunteer to be a number 2, to be a support to whoever is doing the chest compression, so that you have 2 staff members that are going to change from time to time so that they don't tire easily. 2 is I need a timekeeper. From my experience, both working in the hospital and going to other hospitals to work as a locums physician, I've realized that the house supervisor or the floor charge nurse tend to assume this role. And so once you identify them, so request that they inform you every 2 to 3 minutes for you to switch your CPR and administer your IV epinephrine. Okay, so those 2-3 minutes calls, I usually tell them to tell me every 3 minutes, so that I try to sync both the switch in the CPR providers and the IV drug administration. So I tend to occasionally push the CPR providers just a little bit more, an extra 30 seconds or 1 minute, to just make this rhythm easier to manage. And then, of course, the respiratory therapist. Usually, once a code blue is called, the respiratory therapist, they already assume their role. So just identify them and request that they give you a confirmation once they've successfully intubated a patient. And so that you can, of course, listen to the chest and make sure that it's symmetric and there is good airway in both lungs. So again, these are your core triangle you're trying to build, because they're going to play a major role and they're going to help you control the crowd. Because once you establish this core triangle, everyone else who is just an onlooker tends to shift back, and it's obvious those who are more involved in the resuscitation. Of course, you want to identify the RN who is going to be administering drugs, and usually I've seen these are usually the nurses who are taking care of the patients on the floor. And so once I identify them, I request that they give me a verbal confirmation for any drug they administer, just to keep track and just for emphasis sake. And then, of course, you want someone who is going to operate the AED, who is going to help us keep an eye on the rhythm whenever we are doing a rhythm check, and be ready to shock. And you want to make sure it's someone who feels confident. Rather than assigning, it's always best to ask who is comfortable operating the AED. So again, these are your core members in the resuscitation, and this helps you to control the chaos and the crowd. So you need 2 staff members for CPR, you need a timekeeper, you need a respiratory therapist or 2, you need the RN who will be administering drugs and giving you confirmations, and you need someone to operate the AED. And so once you've accomplished this step 2, you're halfway done to a successful code blue resuscitation session. And so you move to the next, establish your rhythm for the entire process. And establishing your rhythm, it involves a recollection of your ACLS training, of course, and executing it as in an organized and systematic way while, carrying the team along. So again, you're the team leader, you're the captain. And some of the points to remember is you want to avoid interrupting the CPR as much as possible. Since this is the most important aspect of the process, you want to ensure that your core triangle team members are executing their roles efficiently. You're going to make sure that pulse check should only, and I want to emphasize this, pulse check should only be done when you have an organized rhythm on the monitor during your pulse, during your rhythm checks, okay? So you shouldn't interrupt CPR for pulse checks. So again, it should be only when you have an organized rhythm. Very frequently, I hear during a CPR, during a resuscitation session, I hear staff members calling out while CPR is going on, hey, can we check a pulse? Can we check the pulse? And we don't check that unless you have an organized rhythm. If you have a disorganized rhythm like a ventricular fibrillation or ventricular tachycardia, you want to plan to shock. You don't start checking the pulse. Again, only for organized rhythm, sinus tachycardia, sinus bradycardia, atrial fibrillation, atrial flutter, organized rhythms only. And then 4, remain calm, avoid shouting at team members or any form of disrespect as you supervise, okay? So establish your rhythm. What do I do? This is pretty much what I do. So, we do CPR for 3 minutes. After 3 minutes, I tell them to go ahead and switch dose, giving the CPR and administer a dose of epinephrine. They continue CPR again for 3 minutes. Now, this is 2 to 3 minutes. Again, I know the recommendation is for 2 minutes, but I try to sync this just to have an easier rhythm. So you do CPR again for 3 minutes, and then you do a rhythm check. So you can see CPR for 3 minutes, CPR provider switch with epinephrine giving, another CPR round for 3 minutes, then you do a rhythm check. If it's a non-shockable rhythm, say if it's asystole or PEA, then just tell them to resume CPR. Okay, so if you see an asystole, resume CPR. If it's a PEA, that means you see an organized rhythm on your rhythm check, then do a pulse check. If there is no pulse, then resume CPR. Okay, so you do another CPR for 3 minutes. After 3 minutes, they tell you, the house supervisor, your timekeeper tells you it's 3 minutes. You administer epinephrine, tell the CPR providers to switch, repeat CPR for another 3 minutes, then stop, do a rhythm check. If it's a shockable rhythm like VTAC, VFib, tell the AED operator to get ready for a shock while you continue CPR. Again, you want to continue CPR as often as possible without interruption. And then once they are ready for the shock, then the AED provider clears everyone for a shock by shouting out, all clear. And once you deploy that shock, resume CPR again. And then, of course, when you resume that CPR, this is the time where after maybe a round of CPR, you can tell them to stop for a rhythm check. So after you've given a shock, rather than going through 2 rounds of CPR and giving epinephrine in between, this is when you want to see the effect of the shock to know if they are back in normal rhythm or if they still have a shockable rhythm. And then you kind of maintain this cycle till you achieve return of circulation, of course. So in your step 4 and step 5, this is where you provide a feedback to the team and be open to suggestions. You can, if patients are not responding, then you can ask if anyone has any suggestions, but politely encourage faster and deeper CPR if it's not adequately performed during the resuscitation. And don't forget to applaud them with positive feedbacks if they are doing a good job. Request suggestions from team members, if ROSC is not achieved despite resuscitatory efforts, and by ROSC I mean return of circulation. Then troubleshoot. Consider administration of sodium bicarbonate because you want to have a high suspicion for things like severe acidosis in patients who persist in asystole or PEA arrest, since acidosis is a common trigger for these conditions, for this level of for this kind of cardiac arrest. And then, of course, consider IV amiodarone if you've had to shock repeatedly and patients remain in ventricular fibrillation, giving some antiarrhythmics might help bring them out of that fibrillation. Avoid open rebukes in the middle of an episode and provide feedback privately if possible, or during the final feedback after the code blue session, and not during the episode. It can feel embarrassing sometimes for whoever you're trying to correct. So again, for the step 6, your post resuscitation management, management of the patient after a successful resuscitation is a major component. You need to try to prevent recurrent cardiac arrest. Sometimes we bring them back and then they go back into an arrest. So you want to prevent that. You want to stabilize their vital signs. You want to assess the possible primary cause of the cardiac arrest. And then you want to transition them smoothly to the ICU, which is the appropriate level of care after that. Once a pulse is confirmed, blood pressure should be measured immediately to initiate fluid boluses or pressor support. Lab draws, including ABG, can be helpful to determine the primary cause of the cardiac arrest, like CBC, metabolic panel, cardiac markers. Then that's actually when you give your initial ventilator settings. You communicate that to the respiratory therapist. Then you want to contact the ICU staff, and you should inform them. Usually the house supervisor will inform them during the episode, and so they start preparing a room for the patient. The family should of course be notified as soon as the patient goes into a cardiac arrest, and so that if they need to come over to the hospital for further discussions, they can. So you want to make sure someone is calling the family just to let them know. And the patient should be transferred to the ICU as soon as a room is available. And of course, once the family is around, you want to give them a briefing, or you want the primary provider to give them a briefing of what could have happened, what happened with the cardiac arrest, and their prognosis and the subsequent plan. If there is going to be a change in provider when they go to the ICU, you also want to let the family know. So what are the take-home points? The take-home points are, a successful resuscitation requires team effort and organized supervision with maturity and respect. Your ability to establish your core team players early and establish a rhythm which can help you execute a calm session while maintaining mutual respect and effective communication is key to a successful resuscitation. Again, this is a practical scenario. This is my experience, and I'm hoping that this short lecture will be helpful to you. Code blues are unavoidable. They do happen. We don't want them to happen, but they do happen, and so you should be prepared as a physician, even for the primary care providers, family medicine providers, because you never know where you're going to be, and you're going to be the physician there. It could be in a plane, it could be in a hall, it could be in the market, it could be anywhere before the EMS team arrives. So especially in the hospital setting, of course, where more advanced rather than basic life support is being given, and you need to work with a team, you want to know how to navigate these scenarios. Okay, so thank you. I hope this was very helpful to everyone. Thanks.